So today we're going to talk about our preparation, everything we need to set up before we actually intubate someone and why that's important. So obviously if you start to intubate someone and you haven't properly prepared, there's a lot of things that can go wrong and you're ultimately dealing with someone's life there. So you need to make sure that you're ready for anything that could go wrong and that we've treated anything we can to hopefully avoid that and have a really easy intubation. So one of the first things is just having a very systematic approach to how you do things every time. I always have my oxygen. You're going to have them on oxygen, high flow, whether it's a normal breather or nasal cannula. You're going to have your adjuncts out, MPA, OPA, your BVM. You can have your PEEP valve setting out. You have your different blades. So when you get to the blades, you want to make sure that the light's tight and bright. That end piece can come unscrewed and will fall back into someone's throat. You're not going to be able to pick it up with the McGills because it's too tiny, the little end piece. So when you pull your blade out, make sure it's screwed on, make sure that you've got a nice light, make sure you have backup sizes, and then you can also check those. After that, you're going to move to your different tube sizes. So you want to, probably 3 different tube sizes, the one you plan on using, one lower, one higher. You want to go ahead and make sure that you're checking when you blow it up that this cuff stays inflated and doesn't have any kind of cracks or leaks in it, okay? So once you've got that ready, you've got your backup eye gels, King Airways, and then your bougie if needed. When you get in there, if they're really anterior, you've got that. You also have your suction, both Yonker and your French catheter, your ET tube, end-tidal CO2 for your tube, and then a way to secure it. If you don't have the tube tamers, whether that's tape, however you go about securing your tube, you want to have that available as well. And then there's some other things when we're prepping that you can also be paying attention to as you're laying this stuff out. There's some acronyms we can go through. So the LEMON acronym, which is just looking, evaluating, and giving them a Mallampati, seeing if there's an obstruction, and neck mobility. So when you get to you're looking at the airway, you're evaluating, you can do the 3-3-2 method, which is 3 for the mouth, opening, 3, and then 2 between the hyoid and thyroid, I believe. It's in your book. I know 3-3-2 is in your book. Mallampati, which is the score of 1 through 4. So you want to look at that. That's how, when they open their mouth, how well you can see. Give them a score on that. Obviously, obstruction, you would probably have that universal. I've got an obstruction. Neck mobility. But for the obstruction, also think about teeth, right? Do they have dentures or not when you get in there? If they do, go ahead and have them take them out. The other one is you can think about moans, which is your mask seal when you start ventilating your patient. If there's an obstruction or maybe extremely obese patient, again, age, anyone over 55 starts becoming someone we want to pay closer attention to. Do they have teeth? Again, the dentures, and stiff lungs. That's the S for moans. Because that's going to depend on how we ventilate this patient, right? The elasticity of the lungs. Heaven is one, where we talk about the hypoxia, the size of the patient, right? The extremes, so someone that's really big or really tiny, that's going to change their airway. Anatomical challenges, so people that are on trachs already, right? How do we clear that trachea? Obviously, we're not intubating those patients, but we've got to control that airway. We've got to clear that trach, so knowing how to do that. The V is for like vomit, blood, fluids, clearing that with our suctions that we've gotten ready. And then blood loss. They have a lot of blood loss. If they do, we've got to pay attention to that as well. Neck mobility. You're going to see that in almost every acronym for your preparation, and it's because it's a big deal. If you have someone that has kyphosis and a very stiff neck, when you get into intubating and you start looking at that 0 degree to 45 degree intubation, that becomes a problem, right? Because their neck is just stuck in this position. So think about those things. Think about whether you need to have PEEP for pre-oxygenation, or maybe put them on CPAP for your pre-oxygenation. Managing, I know Dr. Brain was at it, she was talking about managing the blood pressure prior to intubating, right? Because some of our pharmacology meds that we give for intubation might lower that blood pressure just enough that it makes it fatal. So fixing those things. Also know some of your contraindications for intubating. Age is a big one. Really small kids, acute epiglottitis, that's a big one. Those are the ones that we usually try not to mess with at all. Known allergies to the meds that you're going to give. Can't intubate them. And then other ones to kind of think about are like stridor or extreme traumas, things like that, where you start looking into other forms of airway management. So general tube size to think about, it's kind of a 7 to 7.5 for women, 7.5 to 8 for men. So that's kind of a general starting point. It does not always mean that they will be that 7.5. One of the reasons why I love having the bougie is for that reason right there, is when you get your first view of the cords, if you see that it's not gonna fit your 8 that you have for this guy, and he has something going on and he's only a 6, you can go ahead, because you're ready and you're prepared, you can mark, you can put the bougie in, and then you can put the tube size that you decided you need to adjust up or down to for that patient. So once you've got everything prepped, it's simply that. You're opening your airways, you're selecting your adjuncts for the appropriate size. One of the first things you're gonna do is you're gonna ventilate this patient with a BVM on room air, okay? So when you get in, initially it's not gonna go to oxygen, it's just a room air ventilation. And the thought process behind that is the same concept. They haven't been moving very much air. So the 21% that you're getting from room air is still better than what they were getting in. We wanna get those breaths going as fast as we can. So you're gonna get this going with your adjunct and your BVM without oxygen. You're gonna listen to the lung sounds at that point and find out, are they present, are they equal, what can I do to fix it, what's going on? And then at that point, you're gonna identify your need and you're gonna put the BVM on oxygen, identifying your need to intubate. So at that point, you kind of move to the next set on your table. It should be set up as you're gonna flow through the actual call. So the next step is, I've already prepped this, I know it's ready. So I'm ready to intubate. So now you start getting your equipment out, right? You've checked your cuff already, so it's not inflated, you're ready to go with that. Then you're ready to pass the tube. And we'll save that for just another little chat on all the stuff that goes in with passing the tube. But really the most easiest thing you can do to set you guys up for a successful intubation is the prep work. So if you take your time, put your patient on oxygen, and you're following the steps, and you're treating everything you can possibly treat leading up to that intubation, 9 out of 10 times you will have a completely successful intubation, because you've eliminated the worry, right? You know that you've taken every one of these steps to get there. So when you're there at this point, and it's time to intubate, you know that that's where you should be. There's no second guess of, oh, did I do this? Did I do that? Did we try to pre-oxygenate? You know you've followed this systematic approach. If you do that, you will not miss things. So I believe personally, it's less about getting the skill of putting a tube in an airway and more about preparing yourself for success. You do that and you'll get it every time. Some key points to think about up to that is pharmacology. There's a lot that goes to it. Obviously, the small ones that we nail every time, oxygen, albuterol, Atrovent, nitro, but really just sit down and think about, do I want to give fentanyl versus Versed, or fentanyl versus ketamine? You know, well, is it a COPD, or do I need some kind of a little extra bump for bronchodilation? I might go to ketamine. So knowing your pharmacology is big in your prep work. You can step back and know, okay, instead of those I'm gonna go with these because of this reason. So kind of, again, know your pharmacology, but you do it the same way every time, guys. You'll get to that point where you're setting this up and you're doing stuff while you're able to identify other things going on in the room. Instead of just getting there and your patient's desatting and you're just fumbling around looking for things. Okay, so the better you get this stuff down in class, the more successful you will be when someone's begging for help out there. That's a different ballgame. Yeah, I think that's all the prep.